Welcome to Acuity Acumen, the podcast where we illuminate leadership and inspire change. I'm Deanna Armstrong, an executive coach working with leaders in the life sciences and biotech industries to help them sharpen their leadership skills and drive real change. This podcast is proudly sponsored by Armstrong Walker Coaching and Consulting, where we empower leaders to reach their full potential. As AI continues to transform industries, the need for soft skills like self-awareness, emotional intelligence, and authentic leadership has never been greater. With CEO tenures at an all-time low, leaders today face high pressure to not only reinvent their organizations, but themselves. It's not enough to manage strategy. You need to connect authentically with your teams and lead with purpose. Each week, we'll explore actionable strategies to help you navigate this high-stakes environment with confidence. Remember to subscribe on YouTube and follow Acuity Acumen on Apple Podcasts and Spotify. Now, let's dive into today's conversation. Welcome to Acuity Acumen, the podcast where we illuminate leadership and inspire change. I'm Deanna Armstrong, an executive coach working with leaders in the life sciences and biotech industries to help them sharpen their leadership skills and drive real impact. We are excited today to have Dr. Rick Snyder, president of HeartPlace and just a phenomenal figure here in the Dallas-Fort Worth area. Rick, welcome to the show.
I'm excited to be here, and thank you for those very kind words.
You're so welcome. So I would really like to start the conversation about leadership. One of the big things that we focus on is really helping to train the next generation, but also to speak to people who are in leadership roles like you. So when you think about leadership, what does that mean, that word mean to you?
Well, I think leaders really, leadership has been described as those individuals take the responsibility for identifying the potential in people and processes and developing that potential and really finding the talent, whether it be cognitive talent, whether it be leadership talent, and mentoring that and developing that, because at the end of the day, it's about people and impact. And people are going to give us the biggest impact, whether it be political impact, economic impact, scientific impact. And that's what I think really ultimately, when you drill it down, that's what leaders do.
Mm-hmm. And you mentioned three things. You mentioned the people part, but you also said that the like medical part. I just realized we forgot to say who you are. So tell us about Dr. Snyder, like your background, who you are, and how you got to where you are today as president of HeartPlace.
Well, as a physician, I'm a doctor. I'm a cardiologist. I treat patients with general cardiovascular disease, heart failure, transplant. I'm board certified in all three of those. But that's kind of my clinical job. As I like to tell physicians, we're going to have more impact on the healthcare our patients receive through our work in legislative chambers and regulators' offices than we will in exam rooms and operating rooms. Because as a physician, I treat just one patient at a time. But as a physician advocate, I can help treat a whole county, state, and country all at once. And so that would never hit harder to me as when back in 2001, 2001, when we were having the tort reform crisis in Texas. I would be having a patient at Medical City, Dallas, who had a heart attack, needed a bypass, but I could not get them to have a bypass because our thoracic surgeons or heart surgeons had lost their med-mal insurance. So they would say, I don't know, because they're getting insurance day to day from Lloyd's. So here's a patient who met all the guideline criteria. They needed to have access to care, and they couldn't, because more and more that patient-physician relationship, which should be the most important aspect on how the type of healthcare people get, it's now being imposed upon by third parties, not because of science and education, but because of politics and economics. So because of that, I started getting involved in the political realm. So I served as president of Dallas County Medical Society during West Nile. And that was a very interesting experience. Worked very closely with County Judge Clay Jenkins, progressed up the realm to become president of the Texas Medical Association. So we have 57,000 members throughout the state of Texas, and our vision is to improve the health of all Texans. You can do that scientifically, you can do that through advocacy in the legislature, in the judicial branch, in the executive branch. So again, I don't care how we get there, whether it's in a legislator's office or it's in a boardroom, just so we get there. And some of the very prominent examples we talk about in terms of healthcare, we're talking about things like insurance reform, payment reform. We can talk about things like abortion or fentanyl or different aspects that are really impacting that care and that patient-physician relationship. And it's something we have to defend.
Yes, and I'm glad to see physicians standing up, right? So I was in biotech on the other end for over 20 years, and when all these different changes started happening, I'm like, the physicians need to stand up. And one of the things that I actually did, I was working with neurology at that time, and so I worked with the neurology team here in Texas, the physicians, and they started. I brought a lobbyist in, and as a result of them working with our lobbyists, they hired their own lobbyist, and they began to advocate more. So I love the fact that you were doing that, because it's very important for patient care.
Absolutely. It's, at the end of the day, it comes to access.
Yes.
We talk about coverage, but coverage is not the same thing to access. And access to a waiting list is not saying the same thing as access to health care.
That's powerful. Access to a waiting list is not the same as access to health care.
Correct.
And so one of the ways that you're doing that is through working with the legislatures. So do you work also with other parts of the ecosystem when it comes to the healthcare industry? So are you working with the hospitals? Are you working with the pharmaceutical companies, the insurance companies, and all of that as a part of this movement?
Well, one of the things I do, Blue Cross Blue Shield in Texas has a Texas Physician Advisory Committee. I've been on that committee now for 6 years. We meet quarterly to compare notes, because we talk about there's really kind of three aspects of healthcare. There's the payers, physicians, and hospitals. And sometimes we're not all aligned. And so what we've been doing for like the last 6-7 years is meeting with them quarterly with their CEO and their team and kind of comparing notes, what the physician experience is, what the patients, and kind of giving them feedback. And at the same time, they're giving feedback to us. Because in Texas, 75% of the commercial insurance is really self-insured. Companies are really being self-insured.
Right.
So the insurance companies are really acting as administrators. So they are representing the companies and the employees and trying to get the best access for them. So we're trying to work with them. We also do so with United. From a legislative standpoint, in fact, this morning I had a Zoom political action committee meeting with U.S. Congressman Greg Murphy from North Carolina. We did that for about an hour this morning from 7:30 to 8:30. He had a little bit of a challenge because in North Carolina, they have the hurricane. They're having a little bit of a problem with the weather. But working with those folks, I think it's very important. On the private level, I'm involved in several biotech startups. One here locally in Texas, which is a joint venture with the University of Texas system on how to bring new innovative products, therapeutic products, using specifically in this instance biodegradable polymers with a therapeutic agent, which I think could bring a lot of benefit. So it's not just the physician providers, it's trying to get new innovative technologies that solve some of the problems. So I think really for physicians as leaders, we need to play a role in all of these buckets, working with the innovative scientists to say, how can we bring these great ideas to the clinic, and what does that look like from a meaningful standpoint?
And so one of the things that I find interesting, and what I would hear a lot when I'm working with physicians, is that you go to medical school, you go to your residency, and you go to your fellowship, but you're not taught the part about business.
Correct.
You're not taught the part about leadership. You're not taught the part about working with people. I don't know if it's still like that today, and that's what you're hearing from some of the younger generation. So when you're talking about all these things and all these facets that one needs to be involved in as a healthcare provider, that can seem overwhelming.
It absolutely could be. And that's, I think, one of the opportunities for improvement, I think, in training of medical students, because we're going to play much more of a role than just a clinician.
Right.
And so I think we need to look at how do we expand that basis for that. So the Texas Medical Association, recognizing which you just pointed out, changed some of our annual meetings. So for example, in the fall, it's called the Business of Medicine.
Okay.
And then in the winter, it's the Leadership of Medicine. And when I was TMA president, I would go around the state, and that's one of the roles you play, going around to all the med schools. We have 16 now. and meeting with the presidents and the medical students. And one of the slides I put up there is, while medicine is a science and healing is an art, healthcare is a business, a big business. And we can actually quantify that. Last year, we spent 4.5 trillion with a T dollars last year. That was our national healthcare expend. This data comes from the Office of the Actuary, Office of Commerce, and CMS, Center for Medicare and Medicaid Services. By 2030, it's going to be 6.8 trillion. On a per capita basis, last year we spent roughly $13,500 per capita, and that's in the setting of 8% uninsured. Compared to every other country in the world, we easily outspend every other country in the world, and almost all of them by 2 to 3 times. So this is not an insufficient spending issue, it's a cost efficiency issue. The biggest aspect to access to care is going to be cost. And can we get coverage and meaningful access? So this is a problem. So we are about to see a tsunami of patients. All the baby boomers will be on Medicare by 2030. We're going to have the largest over 65 population as a percentage of the population pyramid we've ever had. In 2020, we had 55 million people over 65. By 2030, it's going to be 72 million. So the demand is about to skyrocket. At the same time, the median age in this country of a board-certified physician is now 56. It means half of them are over 56, half of them are younger, and the mean is 57. So we've got to get a way to increase the physician workforce. At the same time, so how do we solve this cost curve? If we can't afford it now, how are we going to be able to do it in just 7 short years? So this is why I think physicians need to be at the table. Where do we get these cost efficiencies? Because there's a lot of opportunities. We were speaking again this morning with the representative from North Carolina about this and how, as a legislator at the federal level, we can do that, but also in Austin. I tell our physicians, we need to make the Capitol buildings in Austin and DC as familiar as our own hospitals. We need to make our legislators as familiar as our own patients.
And so you mentioned, like, during the Texas Medical Association meeting, you have all these different themes for each one.
On leadership.
But how,
and then the business of medicine.
In the business of medicine. So how are we also preparing them to talk about these legislative issues, because it's important also for physicians to be there lobbying on behalf of their patients and on behalf of themselves.
Absolutely.
And so that's one thing. But the other thing I thought about is that the shortage of physicians, right? You mentioned that you don't have when you look at the age and population of the current physicians, I'm guessing that a lot of physicians, people are now saying, I don't want to go to the MD program or a DO program. I'm going the advanced practice provider route, right? You see that outpacing the number of people that are enrolling in medical school. I mean, it's just growing more and more as you see more of the physician's assistants are advanced practice providers and then nurse practitioners as well. Where do you see that trend play? How do you see that trend playing into what you do? And are those people a part of the Texas Medical Association?
The Texas Medical Association are physicians. And so that would be MDs and DOs, for example. I think the APPs are a critical part of the team. They help really allow the physicians to operate, we call top of the license, for really the most acute care patients. Now, the difference is you got to understand what's the training difference between those two. Your average, let's say, a nurse practitioner or a physician assistant has about 700 to 900, we'll just say 1,000 clinical hours before they can have that designation after their name. To put in very simple terms, a third-year medical student does on average 2,500, 3,000 hours. We don't give them independent practice. We make them go to fourth-year medical school, give another 2,500 to 3,000 hours. So you can imagine that by the time you graduate from med school, you have MD after your name or DO, you have about 6,000 clinical hours, 6 times what a nurse practitioner has. We don't give them independent practice. We make them go do an internship. So on average, a physician, before they are allowed to have independent practice, have about 10,000 to 12,000 clinical hours, almost 10 times. So that's a difference. That's a huge different experience. And you cannot shortchange the value of that experience in putting in the time. Now, I think they can clearly help be part of the team, But I don't think most patients would feel comfortable with someone having maybe 1/10.
Right.
Because then why would you have a medical school? Why would you say you've got to do third and fourth year? So I think it's a lot of time. And I think a lot of people said, I'd rather go in and start seeing patients and treating patients under the direction of a physician as opposed to go through the whole med school route. Because what I did as a cardiologist, it was 4 years of med school, 3 years of residency, and then 4 years of fellowship. That's about 25, 30,000 hours. Okay, so you can see.
And I want you to have that training if you're operating on me or my loved one, right? It's very important, right?
But when I started, because I went to med school at UT Southwestern here in town. I went med school, residency, and fellowship. At the time, I think we had 4 or 5 med schools in the state of Texas. This was between 1983 and 1993. Now we have 16. And we need more. And it's not just the med schools, it's got to be the clinical training programs as well. Now, fortunately, we've been successful in advocating, and it's now state law. It's been for several years now. For every new med school seat, you have to have 1.1 residency slots. Because we don't want to train medical students.
They have nowhere to go.
And they have nowhere, and we're exporting them to different states. We want to be the importer of trainees who've completed med school, who need to do their internship and residency, because our state's growing. It's growing massively. Dallas-Fort Worth is now up to 8.1, 8.2 million people. Some projections has it will be the largest metropolitan statistical area in the country by 2100, almost around 30 million. Be larger than New York, Chicago, LA, Houston being number 2. People want to come to our state. We have a very good regulatory environment. We have a great biotech sector. Things are happening here, but we've got to match that population growth.
Right, and that's exciting, right? This whole biotech thing, that's the other part of what we talk about. This, I'm calling it blooming. I want it to be booming, but we're blooming right now. So you mentioned that you've been a part of this in different ways by investing in some startup companies in biotech. When you think about what's happening in Dallas right now, we didn't in 1983. We didn't know that this would be happening. When I started in 1999, there was really nothing. So I'm excited that this is happening. What do you hope to see come of this investment, like in the Texas Research Corridor in Plano, the city of DeSoto doing all the great things that they're doing? You mentioned Pegasus, I think, earlier.
Yeah, Pegasus.
As well. It's as a person that's been in this area for so long, what do you see this? Where do you see this going?
I'd like to see Dallas-Fort Worth as being a hub, if not even more prominent than we see in Silicon Valley or Boston or in the Duke corridor, where you see a lot of the biotech innovation happening on the coast. I see Dallas-Fort Worth and also Houston area. We'll just say Texas-centric as being very prominent. But you look at that, it's really kind of anchored by UT Southwestern. When I was there, we had the Nobel Prize winners, Goldstein and Brown, who identified the LDL receptor, for which now we take statins, and it's been a great leap forward how we treat and prevent cardiovascular disease. But we can certainly do a lot more. Lyda Hill has the Pegasus Park, bringing all these different labs and centers together, where you can have water cooler discussions about different ideas. The same thing in Plano. I've been involved with a local biotech company here. I'm also part of some of the investment group, because you got to not only have the great ideas and the great minds, you got to have the economics where there's an interest in investing in different ideas and those type of developments. So Dallas-Fort Worth seems to have all the really critical criteria and elements for that. We're also very centrally located, which helps.
What did they say? 4 hours from either coast, right?
From either coast, right. That's right. And so a lot of my physician colleagues also participate in either a private venture or serve as a consultant. My wife is the chief of the Baylor Scott and White Advanced Heart Failure Transplant Program, and she serves for the whole system. And so she serves on a lot of advisory boards, I think 10 different companies, advising them about what would be, how to modify the different devices that they use, what was the right type of patient, doing a lot of trials. So getting the physician population and the physician workforce to not only see patients, but help develop the new ideas for the new generation to benefit of not only patients, but physicians. So do those trials. It doesn't matter if you're in academia or if you're in private practice. There's a lot of very vigorous activity going on here. There's different models about doing trials. I know a lot of neurology groups, Neurology Clinics of Dallas, which we work with as what's called Aspen Physicians. They have a very robust research arm doing a lot of trials, partnering with different biotech companies.
I was at an event recently at the old EDS, which is the new Texas Research Quarter, and I was impressed. We had a professor from UT Southwestern talk about the fact of how Dallas is poised to be an excellent location for clinical research. One, because of the diversity of our patient population that we have
which
here.
is perfect. Yeah.
Of course, all of the medical schools, right? Like you mentioned, UT Southwestern. Well, now we have TCU and
TCOM.
And TCOM, and so we're growing over there. So I was very surprised, like almost, I wanted to say, if not number one, definitely in the top 5 places where it's a great place to have clinical trials and to be able to.
Now, but I think we're poised
Yes.
to compete for, one of those top 2 or 3.
Yes. So that's exciting to hear about those things that are going on here today, for sure. But something that has resonated throughout our conversation is that every time you say something, you say, I've led this, I've led this, I've led this. And people are asking you to be a part of that movement. What is it about Dr. Snyder that brings people to you to say, hey, we want you to be along with us on this journey?
Well, number one, I think it's participated as a team. I'm very much about a team, but it's kind of get out of the comfort zones. When I tell physicians, we need to get out of our comfort zones and really see what's going to have the biggest impact on what type of healthcare our patients receive. It's either through legislative issues, regulatory issues, scientific issues. And I think really the vision of a physician has to encompass all of those things. And I think as I got that inspiration, watching my father. He was a businessman, built a very large private company. I'm the black sheep of the family. But
a cardiologist, and you're the black sheep.
I'm the black sheep of the family.
Oh my gosh! Well, what is your family doing? I'm like, okay.
But my father was part of the. He served under President Reagan and Bush 1 on the NAFTA business advisory committees. There's various committees that he did for the federal government, and I watched that. And I saw the impact that. And again, the relationship, North American Free Trade Agreement, that's NAFTA 1, how that unleashed a lot of economic dynamism in North America, and how that could really unleash the potential. And again, I'd like to see where's the potential in kind of helping bring these folks together, either from an advocacy standpoint, from a scientific standpoint, from an exploratory standpoint. That's what gets me jazzed up, really, kind of looking at the big picture.
And that connects the dot a little bit, because you seem so comfortable in that political legislative piece. Like that's a little, that helps me understand, because you were a kid sitting up watching your dad.
I was watching my dad
do it, yes.
and give speeches to large rooms of people, which I thought was very impactful. There's an old expression: if you're the smartest guy in a room, or gal in the room, you're in the wrong room.
Right.
And I knew I was not going to be the smartest scientist necessarily, but trying to get those people together, or the smartest doctor, get those people together and really commingle those visions and that culture, and really doing that for the greater good. I think when you bring them all together, you consolidate some of the greatest minds and some of the greatest cultures and visions. The impact and the return on that, it has a multiplier effect. And that's always been very satisfying to me.
Yeah, so you come from a legacy of leadership.
I do. And my mom and dad, my mom was the vice chairman of the company. And so
you had strong women in leadership too.
Very strong women. And,
okay.
And again, my wife is...
And I was going to say yes. Oh, wow.
So I was the first president of the Texas chapter of American College of Cardiology. My wife is currently the president of the Texas chapter of American College of Cardiology. She's on many national boards. My big problem with my wife is knowing when she's going to be out of Texas. She's always going to Chicago or when she speaks all over the world, in London, Prague, in terms of her expertise in terms of heart failure and transplant. I like to say that the real talent of the family is my wife. I'm just the eye candy trophy husband. And unfortunately for her, it's a consolation trophy.
No. So what? That's interesting then, because like my mom was a stay-at-home mom. Then she, after my father passed really young, then she started working. So and most of the women in my neighborhood actually were stay-at-home moms. So I think that's unique to have a mom that was a leader and your parents partnering together, and now even to have a wife that's in leadership. What advice do you have for women, female physicians who are looking at this podcast today, and just women in general on leadership and being that strong partner with a woman, such strong women?
Well, when you actually look at the population of the med schools and the new doctors coming out, it's the majority women. They are going to be our new leaders, and we need to address their needs because they have different types of leadership skill, different types of personalities that they bring, no less effective, but can be very dynamic. I said, don't be apologetic for playing both roles. I think some women in healthcare or any profession, sometimes people look down on them for being that engaged leader and having a dual role. Don't be apologetic about it. You can balance both. It's tough. But I think it's also a very good example for your young children to see that you're doing something that you really enjoy and you're an independent person. So I always told my wife, because she doesn't, she goes by Dr. Hall. Because number one, I didn't want her sick patients calling me in the middle of the night, but I really want them an example for our kids that, hey, you've got two parents who are very engaged in their professions, but also in that leadership, to have a voice, to really that your voice matters. And that's the most important thing for them. And, in our group, I think we're a 60 physician group, we're up to 10. Not as many women go into cardiology because it's so long, the training process. Most of the time you're not done until you're early or mid 30s. So that's a little bit of a challenge. But the leaders of the future are going to be women, especially in healthcare. And I think they need to grab the horn. So one of the things my wife did is terms of really kind of accelerating mentoring, she created a nationwide not-for-profit organization it's called Women in Transplant and Mechanical Circulatory Support. It's a not-for-profit organization where all the women get together and they talk about what was their journey for leadership. How did they essentially self-mentor, or where did they find that mentorship? And what are the different opportunities to make the next level? Because it's not always obvious, especially to women. And so how to really promote that. So they meet on a regular basis. They have a lot of private sponsors of that organization. And you see, especially in transplant and mechanical circulatory support, you see now a lot of women who are the leaders at their different hospitals and medical schools. So I think that type of model would be great in other types of examples in cardiology or law. But the reality is, which is a good reality, is that we're getting a lot of women in leaders, and they're being respected, and it's certainly a balance. There's the tug between family and your profession, but it's certainly doable. And a lot of people, my wife will tell a lot of her female colleagues that, when is the right time to have a child? Well, there is no right time. There is no perfect time. If you think it's time to have a family, just do it, and continue your parallel track and leadership development and of the various organizations that they're part of.
And I like the thing too is that you can do both.
Absolutely.
Because it used to be a choice. Like society made you feel like either you're a mother or you're a leader, but you can actually do both.
Absolutely.
And I was watching something and the lady said, I can give my family this percentage and they know that. But when I'm home, I'm there 100%, but I travel a lot. So sometimes mommy is 30% there and there are other times where I'm 100% there, but you can do both.
Absolutely.
Yes.
And you got to have the partner who's going to be a partner with you in that. And so we had a deal. I take the kids. We had a nanny, but we made sure the nanny's going to be a live out nanny, because if they lived in, then it's too easy to say, oh, you do that, you do that. So we would each of us would take the kids. I would take the kids 2 days a week. She would take it 2 days a week, and then we had our nanny. But the cell phone helped in terms of scheduling, because I coached the soccer team. She was the the manager of the soccer teams, and then the Girl Scouts and the Brownies and the Indian Guides.
How
And
many kids do you have?
5.
I'm one of 5 as well. That's my sister over there. I'm the youngest.
Oh,
So,
congrats.
yes, yes. I think they forgot about me being number 5, the 4 others. Well, I like hearing that. So, ironically, the new report on women in the workplace by McKinsey came out. It's the 10th year doing this. And one of the things they talk about that even though women are excelling in leadership, a lot of times they're also still the ones doing most of the home work at home.
Right.
So it's great to hear how you and your wife have had that relationship and giving other people ideas on how they can help support one another in their careers and see 2 very successful people. So I think I have to have Dr. Hall on this show too, because
Let me tell
she
you,
is doing so many things.
I think you're probably interviewing the wrong person here in this relationship.
So I would love to have her on the show too and learn more about what she's doing and how she's supporting women in as well.
Well, in fact, tomorrow she's flying out to D.C. because she's on the board of governors for American College of Cardiology. Well, and so we're having our semi-annual meeting this weekend. So she's flying up there, and then they hit the hill on we call it Ledge Conference.
Okay.
So they hit the hill on Monday and Tuesday.
All right.
So
good.
she'll be doing that.
Great. Awesome. I'm loving this, like the work that you're doing, and both of you are living and breathing and making a change. Because I think that's what you've mentioned, impact a lot. And that's what it's all about. And that's what we want to empower people to do here on the Acuity Acumen podcast, is to understand some of the things that you can do as a leader to have an impact, whether it's on patient care or legislative issues in whatever state or in the whole country, right? Because you're also serving on those boards. So I mean, kudos to all you do. I don't know how you have time to do it.
Sometimes sleep takes a back seat.
Sleep takes a back seat. Yeah. So I know we're almost coming to a close. Is there anything else that you would like for our audience to know about Dr. Rick Snyder, HeartPlace, or the wonderful work that you're doing on behalf of patients?
I think it's a passion. It's a culture of passion, and I think, especially from the physician community, I think a great majority of the physicians have that in them, but they see, a lot of them will look around and say, what role do I really have in that? And when I actually go to Austin and DC and bring especially the medical students, they can actually see, yes, you are respected, you have that culture of credibility, you need to exercise that. When we look at our Constitution and the Declaration of Independence, some of the original signers, I think 4 or 6 were actually physicians. Some of the largest healthcare facilities in the country, MD Anderson, Mayo, Johns Hopkins, were physicians. We need to exercise those leadership roles that society has given us, because most of the time, because a lot of them know I do a lot of advocacy, they'll come to my office and they'll start the conversation. Yeah, I was in California last week. I had a heart attack. But before we get into that, what do you think about this new bill that's up there? And what is TMA going to do about it? They want to hear what we have to say.
Okay,
and they want us to lead, and they want us to advocate on their behalf. And far and away, that's going to have a much bigger impact than the one-on-one. Yes, we have a big impact, but there's more. We need to take it to another level.
And you just made me think about something that we totally didn't talk about, because you are also a part of innovation. Your wife as well. Your whole organization, HeartPlace. What role do you see innovation playing in the future of medicine as we go into this generative artificial intelligence, this machine learning, and
I think AI will solve a lot of their problems. It'll help. It won't replace them, but it'll make us more efficient. For example, I still think you've got to preserve that physician-patient relationship. I don't want it to be a patient-AI relationship. It's got to be a physician and patient. And to the extent that AI, either in terms of prior authorization, scheduling, providing information to patients, billing, all these things, automating some of the tests. So I think in the future, for example, when we do a test like an echocardiogram or a sonogram of the heart, instead of me interpreting, I think you see AI is going to interpret it. And even now we're trying to incorporate AI where instead of me being at my computer going like, okay, what do you got? You got this, because that's what we've been reduced to, the most highly compensated transcriptionist. Instead of that, I can be looking at you, and AI can be listening and can pre-populate all of that, so we can concentrate just here.
That human connection.
Get that human connection. Because I firmly believe the most impactful factor in the success of a patient's health is that patient-physician relationship. Once we start denigrating that, once we start dumbing it down to a patient provider, that's the other thing. You diminish the role of the physician by relabeling, repackaging, and relegating our role to that of a provider. We're not providers, we're physicians. We have a Hippocratic oath to the patient. And that's where we owe our allegiance. When we allow other third parties, insurance companies, regulators, politicians into that, then that bond is broken. And the most important factor is really lessened. So we have to push back on that. We should never apologize for defending what it means to be a physician in the patient-physician relationship. And at the end of the day, everything what we're trying to do is try to empower physicians in that relationship. That's really what it all drills down to. And I think when you look around, I think a lot of patients will say the same thing. I've got the payer says I can't do this, or the drugs I can't do this, or this law says we can't do this. So we both, patients and physicians, need to be part of this process to preserve that.
Absolutely. Well, thank you so much for your time. I appreciate you so very much. I've learned a lot.
Oh, I have too. Thank you.
I'm so glad we ran into each other the other day. Well, thank you. Anything else that you want to share? I think that was great, though.
No, I think this is great. I think, when we look at, again, healthcare in Dallas-Fort Worth, and especially the biotech and the AI, it's going to make us much more efficient. And thank God, because we're going to have to be, because of our growing population. And this is something that we should embrace and not be fearful. I think if we get the right thought leaders, the community leaders, physicians, hospital leaders, payers together, we can really kind of collaboratively solve what role this new technology, it's an opportunity and something we should learn to embrace.
Great. Well, thank you very much.
Thanks for joining us on Acuity Acumen. I hope you found today's episode filled with insights that inspire change and drive your leadership forward. In a rapidly evolving industry, your role as a leader is crucial. If you enjoyed this episode, remember to subscribe to our YouTube channel and follow us on Apple Podcasts and Spotify to catch our upcoming discussions. This podcast is proudly sponsored by Armstrong Walker Coaching and Consulting. Are you ready to elevate your impact? Reach out for personalized coaching or to explore Acuity Acumen Leadership Institute. Together, we can illuminate leadership and inspire change. Keep leading boldly and making an impact. Until next time.